What is going on, guys? This is Dr. Ryan Garner with Apothecary Wellness. Today's video is part of a series in which we do an in-depth analysis on a patient case, and this is beneficial for our current and future clients, as well as any other healthcare providers, just to gain some insight to our approach in which we manage patients to get the highest level of outcomes, utilizing the most up-to-date evidence, as well as the lowest cost drug regimens possible. So let's jump into it. Our patient today is TG, a 56-year-old female. She is 65 inches tall, so about 5'5", and weighs 196 pounds and has a BMI of 32.6. Her 10-year cardiovascular risk is 5.8%. She has a history of type 2 diabetes, high blood pressure, as well as allergies. Her current medications include metformin 850 milligrams, one twice a day, Jardiance 10 milligrams, one every morning, glipizide 10 milligrams, one twice a day, lisinopril with hydrochlorothiazide 20-25 milligrams once daily, a diclofenac 1% gel used topically, and a Zelestine nasal spray for allergies. Now, patient's A1C is pretty much at goal at this point, but of course we always want to find ways that we can improve outcomes. Now, the patient's BMI does categorize her as obese, which is a strong predictor of outcomes and mortality. The addition of a GLP-1 agent would be very ideal for her for the reason that she is both obese and has type 2 diabetes. We do ultimately see a plateau, which is essentially our body trying to fight back against this sudden weight loss. So the question becomes, is it something that we can ultimately discontinue, or is it something that we need to continue forever? And the answer to that is that it depends. So we can see in trials like the SELECT trial and the SCALE trial that we do hit a plateau around the 50 to 70 week range. But if we look at trials like the STEP 4, for example, with semaglutide, where there is a diversion in the continuation group and a group that is then given placebo, they actually give us a good idea as far as what that weight regain looks like. In this trial, at 68 weeks, the continuation group had about 17% weight loss, where the group that was originally on the medication but discontinued given placebo regained weight, but still came in at a little over 5% weight loss. If we look at studies like the SURMOUNT-4, which investigated tirzepatide, where the continuation group lost about 25% weight, where the placebo group that was part of the run-in that then was discontinued the drug and given placebo regained but maintained about a 10% weight loss. Even in the SURMOUNT-3 trial, the placebo group that never received the active drug also received a high-intensity intervention for lifestyle changes and ultimately resulted in about a 7% weight loss. So why are these things important? Well, the importance is we want to match the weight loss with the actual outcomes that we're gaining. Now, trials like the Look Ahead that looked at weight loss and cardiovascular outcomes showed an 8.6% weight loss at year 1, a 6% loss at year 9 versus a 0.7% in the placebo group at year 1, a 3.5% weight loss in the control group at year 9. Now, the hazard ratio, or the decrease of that risk, was about 5% less, but it was not statistically significant. When we look at a UK study that analyzed patients from primary care, we saw statistically significant reductions in risk at about a 13% weight loss over 4 years. Other meta-analyses have shown a statistically significant reduction in risk over 9 years when we had a greater than 5% weight loss reduction. Now, when we compare things like bariatric surgery with GLP-1s, the data isn't quite as clear. The Stenberg trial that established major adverse cardiovascular events between bariatric surgery and GLP-1s did show a statistically significant reduction in cardiovascular events in the bariatric surgery group versus the GLP-1 group. The bariatric surgery group had about an average BMI of 40. The GLP-1 group, however, we don't know what their BMI looked like, and we don't know what the weight loss looked like. So the data is relatively incomplete. The data that we have available to us does tell us that 5 to 10% or greater weight loss is where we'll start to see statistically significant decreases in cardiovascular risks, as well as cancers for patients who are obese or overweight. So could we potentially discontinue a GLP-1 in this patient? And the answer is possibly. It depends on the patient's response to the medication. It also depends on the amount of weight loss the patient receives. One of the things that we really need to consider here is that in most of these trials that do show a regain upon discontinuation of GLP-1, they do not have continued intensive support through the remainder of the study. Typically, these studies had intensive intervention early in the study. However, we do not see the support continued throughout the remainder of the study. This is something that can certainly have an effect on continued outcomes. This patient does not have a history of cardiovascular disease, nor does she have heart failure, both preserved or reduced, nor chronic kidney disease or any signs or symptoms of them. Therefore, she does not need to be on an SGLT2 inhibitor, what Jardiance is, because we're not going to get any improved outcomes from this medication beyond minimal weight loss, as well as blood glucose reduction. Patient's blood pressure is relatively at goal, and we do want to continue that because it is under 130/80 or teetering around there. We do expect optimal outcomes from this blood pressure range. Now, we've talked about before that type 2 diabetics are at an increased risk for cardiovascular disease. It is about a twofold increase. Therefore, reducing LDL with a statin is incredibly important. We have data from the ASCOT LLA trial that did show statistically significant reductions in cardiovascular events with atorvastatin 10 milligrams that reduced LDL around 35 milligrams per deciliter. We could, of course, increase it to a 20 milligram as lower LDL does result in decreased cardiovascular risk. So what is the plan going forward? We're going to first discontinue the Jardiance. We're also going to discontinue the glipizide. Not a big fan of sulfonylureas. They are very strongly associated with weight gain, which obviously this patient being obese, we want to avoid as much as possible. We're going to change patient's metformin to 1,000 milligrams twice a day. We are going to initiate Ozempic at the 0.25 milligram dose. We will titrate as tolerated and reevaluate at 68 weeks. Patient is not currently on any statin medications. And therefore initiating a moderate intensity statin like atorvastatin 10 milligrams would be ideal. We'll continue to follow up for any kind of myopathies or muscle aches. We're going to continue her lisinopril with hydrochlorothiazide, as well as her topical diclofenac and azelastine for allergies. We're going to initiate a calorie restriction of about 1,780 calories a day. Now, this is patient's calculated BMR, basal metabolic rate, in addition to the calories burned when digesting food. This is where the patient would need to be for neither a gain or loss in weight. And we'll target a protein intake of somewhere around 70 grams per day. Ultimately, we shouldn't have too much of a change in our A1C. We will see probably about a 0.5% increase when discontinuing the Jardiance, also met by probably about a 0.3% decrease by increasing the metformin dose. We may also see about a 1 to 1.25% A1C increase by discontinuing the glipizide. We should ideally see that be countered with the addition of a GLP-1. We're expecting negligible changes with the metformin cost as we're just changing the dose. We expect the atorvastatin 10 milligrams to run about $48 per year. Now the Ozempic, we're looking pre-rebate at probably about $10,500 and a post-rebate figure about $6,600. Now it is really important to note that rebates can fluctuate depending on who's negotiating them, how much the PBM is retaining, and certainly the medication class. Some medication classes that have more competitors will offer higher rebates, and others with fewer competitors will offer lower rebates. As for GLP-1s, we actually see a pretty substantial rebate being offered for this class because it is a relatively competitive space for formulary placement. What do our savings look like? Well, we're discontinuing the Jardiance, so we should expect about a $6,900 pre-rebate savings and about a $4,400 post-rebate savings, and we're expecting to save about $176 a year by discontinuing the glipizide. So the difference is coming to about $3,500 increased cost with the addition of the Ozempic, pre-rebate and a little over $2,100 post-rebate. Now, again, the GLP-1s, I would actually expect this post-rebate figure to be a lot lower for the reason that rebates in the GLP-1 space are much higher than rebates for most other commercial products. This is one of those cases where we are certainly improving outcomes for this patient, both for their A1C as well as for potential cardiovascular and cancer risks regarding their obesity. Now, we did see an increase in total costs, but that was offset as much as possible when discontinuing the Jardiance. Sometimes this is how it goes. If we are going to improve outcomes for patients, there is an associated cost. Now, we are going to evaluate in 68 weeks or so for patient response and whether discontinuation and supported intervention can still maintain over 5 or over 10% net weight loss. Thanks so much for tuning in, guys. Subscribe, like, follow our page on LinkedIn. Take care.